Shreya, we're ready for you.
All right. So our chief complaint is a 66-year-old man with generalized weakness, nausea, and altered mental status.
Go ahead.
All right. So a patient presented to the ED with generalized weakness and nausea for the past day and altered mental status for the past 6 hours. He was unable to answer most of the questions, but his wife, who accompanied him, said that he started complaining of weakness and nausea after breakfast the previous day. She also said that he has not had any fever, no chills, no chest pain, no dyspnea, and no prior similar episodes. But he was recently treated for a UTI at a local urgent care facility 5 days prior. Yep.
Is this a good place to stop, Shreya?
Yep.
Awesome. Wow. So much to think through. I'm super excited about this, Shreya. So we have a 66-year-old gentleman who's coming in with appears to be kind of like a few days of weakness, nausea in the background of a recent urinary urinary tract infection, who's coming in now with a couple of hours of altered mental status. And I will just tackle on the altered mental status, like kind of broad approach how I'm thinking about weakness and nausea, and let RG layer on the other things. So I think with altered mental status, I haven't actually thought about that in VMR in a while. Our favorite mnemonic is the one that I always go to. So think about like metabolic, infectious, structural, and toxins. And the question is like, what does as weakness, nausea makes something even more or less likely? It doesn't do much for me, to be honest, because like the weakness itself, the first question is like whether it's more a muscle weakness that is actually true weakness, or are we thinking more asthenia? And someone with kind of the background that is provided, I worry that is most likely generalized weakness and asthenia. However, exam would be really informative if something that is involved, the central nervous system. And the nausea itself, again, like nausea, like headache, like diarrhea, it can be a secondary presentation of a reaction to whether it's an intra-abdominal processes, whether there is like dizziness. So nausea can accompany many different things. So again, that is like not as much localizing as we would like it to be. So common things being common, infectious metabolic etiologies would be really important to think through for this patient, and not forgetting about any structural or CNS etiologies. RG, where you at?
No, I completely agree with that. I think the question is the UTI related or unrelated? And I think the closer an event is to, like, if this UTI were 2 years ago, we wouldn't be thinking about it, right? But the fact that it's 5 days ago at least raises the concern that it might be related somehow, and it might be related in 3 ways. And this is a general approach to try to merge things together. The first is assuming that the diagnosis is correct. Is it a complication of the diagnosis, or is it a complication of the treatment? And it's hard to see a complication of the diagnosis directly without an intervening pathology, saying UTI, hypotension, altered mental status, sure, but there has to be a bridge. There's a much more direct connection with medications, and antibiotic encephalopathy is a prominent condition that features commonly used antibiotics like fluoroquinolones, trimethoprim, sulfamethoxazole, all the carbapenems, all of them can cause an encephalopathy, and some of these are restricted to people who have advanced kidney disease. So that's 2 points, right? Assuming the diagnosis is correct, it's a complication of the diagnosis or a complication of the correct treatment. But we all know that the diagnosis may not be correct, and it's a complication of not the right diagnosis, but a complication of misdiagnosis. So if you're trying to relate an event to another event, it's one of 3 things: a misdiagnosis, a complication of the diagnosis itself, or a complication of the treatment. Or you should not listen to, not assume that everything I say is correct and there's something missing in the schema, but that's how I think about it. All right, Sriram, back to you.
All right. So And his past medical history, he's a diabetic and he's been on treatment for the past 15 years. He's on metformin and canagliflozin. Yeah. And for his family history, his father died of an unknown cause at age 70. His brother had a glioblastoma multiforme and died at age 48. Social history. He works as a real estate agent, lives in a rural area, but no recent travel, no sick contacts. Health-related behaviors, he smokes a pack of cigarettes a day, and he has done so for the past 30 years. He drinks socially, and he has no known allergies. I think this is also a good place to stop, and we can talk about the medications and past medical history too.
Oh, right. So the question is, how's the background of diabetes change our calculus? One thing that is worth knowing is that this is a 66-year-old patient with diabetes who's altered. It takes a lot to alter someone who is not, doesn't have dementia, right? So it just kind of makes me think about severity of the illness that he has currently. In terms of like his medications, that's SGLT2 always, I've trained my brain to jump out to me because of his complications of euglycemic DKA. So I pay close attention to the basic metabolic panel to see if there's any acidosis that is going on, ketosis that needs our further attention. But again, SGLT2s can cause dehydration, a higher risk of maybe urinary tract infection. So, and the question is like how poorly controlled the diabetes is, not the fact that he's only on orals and not on insulin, thinking about like how immunocompromised this patient is. But I think it definitely makes me think more about metabolic while having infectious etiology still fairly up there. What about you, RG?
No, I completely agree with that. I think the diabetes in the background is really important. And as you alluded to, both the diabetes and the SGLT2 inhibitors increase the risk of a urinary tract infection. But here's the clincher too. They also increase the risk of misdiagnosis of a UTI. So why would somebody with diabetes get misdiagnosed with a urinary tract infection? The most common reason would be that they have hyperglycemia, have polyuria, and they come in and they say, hey, doc, I'm peeing a lot. And instead of them peeing a lot because they have urinary frequency and irritation, they're having polyuria. And guess what happens to hyperglycemia that's given an antibiotic? It just gets worse and worse and worse. So I would say that you have to be careful in patients with diabetes because they present with polyuria, a symptom that's easily confused and labeled as urinary frequency. And it's also a reminder to check a glucose in everyone who's altered for two reasons. It might be really, really low, or most concerningly in this case, it might be really, 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 really high. And in this patient specifically, I worry that he's been eating as he usually has, and might be in a hyperglycemic emergency, be it euglycemic DKA from the SGLT2 or hyperosmolar hyperglycemic syndrome. Either way, I think a finger stick sugar would go a long, long way. And by the way, Sridham, thank you for being an expert case presenter and having sympathy for this not young scribe.
No, that's okay. I just made sure I wrote everything down according to how we usually do it. So got everything right here. So going to the vitals, his temperature is 100 degrees Fahrenheit. His heart rate is 110. His blood pressures are 80/60. His respiratory rate is 18. And his SpO2 is 94. On exam, general exam, he was somnolent and unable to follow commands. That was normal. Cardiovascular system just showed tachycardia, normal S1, S2. The respiratory system was bilateral, normal vesicular breath sounds. Abdomen was soft and non-tender, and neuro exam showed ANO times 0, unable to follow commands, but he was withdrawing from noxious stimuli and protecting his airway. Extremities showed trace bilateral edema. You want me to stop here or just go to the initial set of labs?
Just in the interest of time, do you want to just give us the initial labs?
Sure, yeah. So the finger stick in the ED was 178. His hemoglobin was 13. WBC count was 14,500. Platelets 360K. Sodium 138. Potassium 4.9. Chloride 101. Bicarb 20. BUN 990. Creatinine 1.8. Baseline was 1.1. ALT 188. Sorry, AST 188 and ALT 122. Billy, total Billy 1.1. Yeah.
All right. Thank you, Shreem. So, those vital signs, that's the one that grabbed my attention the most, especially that blood pressure in the 80s over 60s. Again, with blood pressure, the delta is what matters the most. So if somebody's always lived in the 80s with blood pressure of 80s, less impressive than if somebody's in the 130s, 140s, and now presenting with 80s. Given that this patient is altered, his tachycardia and the blood pressure is low, I'm thinking about hypotension, and kind of it always helps me think about my shock schema and think about what etiologies that I'm the most worried about that could be reflective as hypotension. So, thinking about your distributive shocks, your septic shock, if this patient has widespread infection as an etiology of it, thinking about hypovolemia, like hemorrhage, is that hemoglobin less likely, thinking about again, like dehydration, if someone is not eating, drinking well, peeing a lot, as an etiology, thinking about your obstructive shocks, PE, thinking about tamponade physiology. So in general with him, the one that you're most worried about are probably either thinking about hypovolemic or this distributive etiologies, and we don't find really some localizing symptoms on exam. So thinking about what are common sources of infections into your intra-abdominal, there's no tenderness, pulmonary. Again, physical exam is not perfect. Skin and soft tissue, we really don't see anything. It seems like the neuro exam, although patient hasn't been is not able to follow command, it doesn't have any focality to it either. So I'm going to stop and pass RG for the labs because he's magical.
Oh, I've lost the ability to blush because I've blushed so many times because of you now. What's that called? Energy? No. Tachyphylaxis. My blushing is tachyphylaxed. The labs are tricky because they're giving you soft clues as to what's going on, but nothing definitive. So the white count is elevated, supporting this patient might be infected. The kidney is perturbed, but whose kidney wouldn't be perturbed if their blood pressure is that low? And same reason for the liver. The abnormality of the bicarb being low is consistent with an acidosis from AKI, but as the chat is alluding to, DKA or ketoacidosis is mapped onto the SGLT2, and lactic acidosis is mapped onto the metformin. Both of those are worthy considerations here, and that is the only pathway that's leading us to something productive about the periphery. And at the same time, we have to analyze the possibility that there's something going on in the brain itself. And that especially is something to consider given his brother's history. So the peripheral causes are really soft, but the acidosis signal may be the lead. And if that doesn't bear fruit, then we probably have to go into the brain and see what's happening there. All right, Sriram, back to you.
Yeah. So we then got an EKG, which showed scattered T wave inversions and an unremarkable chest X-ray. So we also have UA results. Just a second. Okay. So and then thinking about an infective cause, fluids and antibiotics were administered, and blood cultures were sent. There was an initial improvement in symptoms and in the blood pressures. He was admitted to the ICU where the blood pressure dropped to 60/40 and started trending downwards. The physicians in the ICU placed a central line and he was given vasopressors to support his blood pressure. By this time, his UA had returned and showed 1+ protein, 1+ glucose, no WBCs, 1 to 2 RBCs, and no bacteria. It's 1+ protein, 1+ glucose, 1 to 2 RBCs, and no bacteria. He also had a lactate that was high, was 4.
Wow. Sherm, is this a good place, or do you have more data for us?
Yeah. I think this is a good place. I think I only have the last alipod after this.
All right. This patient is sick. And I think when it comes to the management of someone like this who is like getting worse, becoming more hypotensive, I think the first branch point is like, what is your pretest probability that this patient is fluid down? And I would say it's okay not to be very gentle, given fluids. Again, like if you're hypothesizing that this is euglycemic DKA, these people are liters and liters down. And if you are worried that this is a patient who with like a progressive like septic shock physiology, again, these people are distributive, leaky, need fluids. So at least like giving few liters up front before we start pressors is a good practice. At the same time, I think like this is the one person that if you have a bedside ultrasound available, it's good to just like take put a probe on the heart. You can check the IVC. You can make sure there's no great effusions coming around that is around the heart that you need to be concerned. And even if this person had like an ejection fraction of like 15-20%, if someone is like septic, distributed, hypovolemic, they still need fluids. So I love the fact that this patient was like given fluids, started on pressor, antibiotics, and when the patient is like that hypotensive and in shock physiology, then you want to give all the treatments that you can possibly think that would be helpful, and then have more time to think about a diagnosis and peel those back. So I think like the blood just culturing this patient, getting the blood cultures, the urine cultures going, just to make sure there's no infection going on, and while giving them fluid back, it's good. And I'm gonna let RG reflect on the lactate and all the other stuff.
Yeah, no, I think this case is really tricky because the lactate is easily explained by the hypotension and or the metformin. And the question is, are those sufficient explanations? And the hypotension is not a diagnosis by itself because we don't have a clear answer for it. And the metformin is very possible, but it's hard to prove right now. And so I think I'm going back to why is this patient presumably septic? And we haven't really quite found a source yet. And the sources that we're missing are all intra-abdominal. Could he have a occult hepatobiliary disease? Could he have a urinary tract infection with an obstruction? And that obstruction is the reason we don't see any pyuria. Or most morbid of all, does he have an infection or an other eye ischemia in his bowel? And so for me, I think once you stabilize this patient, you need to look inside his belly, because that's where the pathology may be hiding and not rise to the surface until he's critically ill. So I think the one thing you have not been able to see is inside his belly, and I would be worried that there's something going on there.
All right. Thank you. So this is the last part of it. So while the resident from the ICU was reviewing the results that were ordered in the ED, he noticed that the tropophile levels that were ordered in the ED had come back at 90. Repeat ECG in the ICU showed obvious ST elevations. The patient was shifted to the cath lab, found to have complete occlusion of RCA, and a stent was placed. Inotropes were required to maintain the blood pressure, and he was transferred to the CCU. He continued to deteriorate and ultimately experienced a cardiac arrest. He could not be revived and died 12 hours after presenting to the ED. Yeah, that was my case. Yeah.
Wow. Shriram, thank you so much for sharing this case. And I'm so sorry to hear about how fast this progressed and the terrible outcome. And thank you so much for sharing this with us. So just kind of, I'm going to just reflect a little bit and then pass the mic to RG to reflect. And, you know, I feel like there is a reason why a lot of the time when people come in, we get the trope, we get those ECGs, and kudos to the ICU resident for following it up and attending the ECGs. And, you know, this is not the typical presentation that you would expect for someone who has having a myocardial infarction. So the question is like, you know, if this patient has been inflamed or on a lot of stress, we know that that can lead to more demand. And I wonder if, you know, there were two things going on. And in the background, these patients are getting more altered, getting more weak, nauseous, whether that is like an infection or something that was happening, or was that someone having a really bad cardiac event and then representing with kind of like a cardiogenic shock type of phenomenon or syndrome that we're seeing, which kind of like the ST segment elevation that argues for like a little more an acute event. So, you know, someone who is like more inflamed and stressed and then comes in and has an MI while he's in the hospital, or when he comes in with that like worsening blood pressure. And I think it also helps. The other reflection that I have is that, you know, as he's like in the 80s or 60s and he's like acutely getting worse, to think about two things. One is like progression of an underlying pathology that you're thinking about, but also a new event is another good reminder that, yeah, things happen really fast and multiple things can happen. I don't know, RJ, how are you putting this all together?
Yeah, you know, I agree with that reflection. I think this is a very humbling case, and I'm really glad that Shriram brought it for us to learn from. I think it's really, really hard to know whether he had an acute myocardial infarction as the entirety of this case, or whether he suffered plaque rupture in the event of a known trigger, and that known trigger is stress. We're talking about systemic stress here. This is why our surgery colleagues ask us to evaluate a patient preoperatively to minimize the risk of this. And don't forget that it's not just surgery that can result in triggering a myocardial infarction. And the general theme here, I think, is that there is this concept in medicine of the silently vulnerable. And patients with diabetes, undiagnosed diabetes, are silently vulnerable to disturbances of their glucose. Patients with metabolic conditions are silently vulnerable to the effects of fasting or eating too much protein. Immunosuppressed patients are silently vulnerable to devastating infections. And the word silently means that they have really sinister disease, but it's minimally symptomatic. And I think you have to respect coronary disease as a silent vulnerability for most older adults, especially older men with diabetes. And so I don't think this if I had to guess, I don't think this person has had a myocardial infarction since his UTI, I think he had a silent vulnerability in his right coronary. And that was exposed by something that in anybody else would have been an outpatient visit. But I don't know that. That's just my gut instinct based on the sequence of events, which is best captured in what happened on that EKG. You know, you go from noise to screaming signal, and I think that tells the story best. At the end of the day, it's humbling, and I think the power to the person who was constantly reassessing their pretest probability of what was going on here and followed up on the data. Shriram, what was your reflection on this case?
So I had a similar case a while back, but this particular case, I got it from the patient safety network of the HHS. And I saw the case and I was like, I had a very similar case a while back and we missed it and the patient had a very similar post. And I saw this case and, everything else in the history, everything points towards a septic cause, probably urosepsis considering a UTI. And we tend to anchor on these things and somehow not consider other causes of shock. And I feel like that's something that's happened, especially when the patient's not able to give history because of AMS. And yeah, that was my reflection on the case. I saw a similar case before and I saw it again on the patient safety network, and I thought it would make a great case to try and teach us that you need to think about everything and not just anchor on what seems most probable.
Yeah, absolutely, Shriram. Such a powerful case, and thank you so much for bringing this. And yeah, and I think the non-anchoring part is something to have like diagnostic humility and not to anchor. And I think even when we are as confident as we can be, following up what we do is also very important. So, just give it therapy, take, especially in your sick ICU, like every hour, every 2 hours, just like reevaluating what we're doing. Because the sicker you are, the faster things can change. And it just being open that even with your best, our best abilities and the bestest of minds, that we might, having that little bit of humility to just check, double check, rethink, always asking like what else could we be missing. So thank you so much. Such a humbling case. Thank you for sharing, Shriram. And Deborah, if you don't mind sharing the teaching points, which I'm sure there are plenty. I can't wait to hear it.
Thank you for having me, guys.
Thank you.
Thank you for the case. It was really good. Yeah, about the teaching points, the mental status, we can always think about the myths that is metabolic infection, structural and toxins, and we have to think about the CNS too. And the metabolic, the hyponatremia and hypoglycemia can be early considerations for the AMS. And remember about the 5S: sugar, syncope, stroke, seizure, and sleepiness. And the metformin, the chat said really good points that can cause euglycemic ketoacidosis, a UTI, a dehydration, and then can cause a rare foreigners gangrene. And the hypotension can be for a shock like distributive, septic, obstructive, can be from ischemia, infection, hypovolemia, hydration, PE, and etoponate. And the patient and this septic we can think about the causes that could be from intra-abdominal, urine obstruction, infection, and ischemia. And in this case, this patient, like the old patients, can present an acute coronary disease with non-expected symptoms, and the DM can be a risk factor. So thank you, everyone. We see you tomorrow.
Thank you all so much. Always a pleasure.
Thank you, everyone.
We'll see you. And that was fantastic, Deborah. Thanks for sharing. Can't wait until tomorrow. Bye, all.